Good afternoon, everyone, and welcome to this webinar hosted by the Global Mental Health Action Network, powered by United for Global Mental Health. My name is Molebogeng, and I'm from Ways for Change, a South African-based nonprofit organization that provides mental health support for children and adolescents through sport, particularly surfing, to help them learn how to identify and regulate their emotions and build social connectedness with their peers through physical activities. It's such a pleasure to have you with us here this afternoon. Thank you for taking the time out of your day to be here at this event. We highly encourage you to introduce yourselves in the chat, as well as the name of the organization and the country where you are right now, so that you can connect with other people that are also tuned into this webinar. For those of you that might not know what the Global Mental Health Action Network is all about, it is a network that aims to encourage greater global collaboration on mental health advocacy and to enable anyone with a professional interest in mental health or health policy, actually, to connect with others who share this interest. This particular webinar is part of a Mental Health for All webinar series that United for Global Mental Health has been running since April 2020. And the purpose of the series is just to explain and share updates on relevant topics and learn more from different people and organizations around the world on global mental health and its many intersections. That now brings me to today's event, which is all about digital mental health. We will be discussing the critical role that digital mental health tools play in addressing service gaps, enhancing accessibility, as well as combating stigma. So we held our first session earlier this morning, where we were joined by a panel of experts to discuss this topic. My takeaways from that session were three things: the importance of designing mental health interventions that are culturally adapted, socioeconomic relevant, and take into consideration, the people for whom they are designed for. And one of our panelists this morning highlighted that this required including the lived experiences of the people who these interventions or solutions are created for. The second thing that I took away was the importance of involving the youth in digital mental health innovations designed for them. And this should be beyond the initial concept and also at an implementation level as well as a governance level. And I thought that particular point was very important. And finally, another takeaway that I took from this morning's session was leveraging the power of social media to raise awareness about mental health in general. Once again, we do have a panel of speakers from various organizations to help us delve deeper into this particular topic as we unpack the role of digital mental health in this day and age across a diversity of cultures, multiple geographies, as well as socioeconomic contexts. Before I introduce you to our panel of experts and speakers, here's a bit of a quick rundown on how today's session will run. So first, we're going to get to know our speakers in just a moment, and they'll tell us a bit more about who they are, the work they do within their respective organizations. After that, we'll dive deeper into the conversation about digital mental health for about 20 minutes or so. And then we'll have another 20 minutes where you, as the audience, have the opportunity to ask our panelists questions. So we do encourage you to send those questions in the Q&A section right here on Zoom. Now, let's get to know our panelists for today. We have Fajana Shanin, we have Dr. John Torres, as well as Dr. Ken Carswell, but I will let them tell you who they are. Our panelists, I think you can go ahead and introduce yourself to our audience. Fajana, would you like to go first?
Thank you. My name is Farjana Sharmin. I'm working as a program manager, mental health program, BRAC, health program. In profession, I'm a clinical psychologist working in the development sector in Bangladesh for past 10 years. And I'm also the focal person from BRAC who is implementing a pilot project with the Bangladesh government. This is my introduction. Thank you for inviting me again.
Thank you, Fajana. And John?
I'm Dr. John Torres. I'm a psychiatrist at Harvard Medical School in Boston. Our team does a couple things I'm happy we'll talk about. We help evaluate and understand different self-help tools. We put apps into clinical use, and then we look at digital navigators, ways to kind of upscale peers to make sure that they can be a new workforce to support digital mental health. So I'm glad to be here.
Thank you, John. Looking forward to engaging with you. And finally, we have Ken.
Hi. Hello, everybody. My name is Ken Carswell. I'm a clinical psychologist by background, but I work now at WHO, where I'm a mental health specialist in the Department of Mental Health and Substance Use. I'm a focal point there for digital innovation and scalable psychological interventions, where we've mostly been working on digital interventions, self-help interventions, and the types of things that we're going to be talking about today that we've developed and released through WHO in some cases. I'm very pleased to be here and looking forward to the conversation. Thank you.
Thank you, Ken. Thank you. I'm looking at our chat box and I see we have people from all over the world. I see you, Isabella from Uganda. I see you, Esther from Kenya. I see you, Anika from Germany, and many others of our attendees today. Thank you so much for joining us and taking the time to be a part of this conversation. Before we get into the discussion with our panelists, as I told you a few minutes ago, that we had such a good session in the morning today, we asked one of the panelists, Roy, about his experience working on digital mental health tools in the Philippines, and take a listen to what he had to say.
I think I just want to begin the session by saying that going digital and digitalization is, I think, inevitable. This is an idea that many people might have realized during the pandemic. So instead of asking whether digital technology is a friend or a foe, we really need to start asking and answering the questions: how do we make it safe, accessible, responsive, and inclusive to everyone? In the Philippines, digital technology has been leveraged to improve access to certain mental health services through telemedicine. For example, telepsychiatry, telecounseling, and teletherapy, crisis hotlines, and mobile applications initiated both by the government and non-government agencies. Our nonprofit organization, Mental Health PH, for example, is developing and testing 2 mobile applications. We call it Gabay, or that's in English, that means guide, that targets or aims to help persons with anxiety and depression, and Sibol, or in English, it's Sprout, that aims to improve well-being of general public. During the pandemic, we developed and released mental health chatbots to help triage service users, asking our social media pages where to get help, and a website directory of mental health facilities in the Philippines. And from what we learned in the development of these digital technology solutions, an important aspect that we keep on doing is involving the service users not only as recipients, but in the beginning and in developing of these mobile applications, making sure that they are at the front and center of these developments and not just mere recipients of technology. By doing this ensures that interventions we're working on are contextualized, effective, and appropriate to the needs of the service users we are targeting it with. And I think I'd like to close to emphasize and remind everyone that when we talk about digital mental health and thinking of digital interventions for mental health, we should not limit ourselves to clinical interventions alone. As a public health graduate, prevention to illnesses is equally important. So might as well we leverage this digital technology, and how can we use this to raise awareness, educate, and address stigma and discrimination, promote healthy practices to maintain well-being in the country. So thank you so much, and excited to learn from other panelists in this session.
Such great insights from Roy, who joined us for our morning session earlier this morning. We also had Dua from Taksin, who was also one of our panelists, and she shared some examples of successful digital interventions for mental health in Pakistan. And here's a quick recap of what she said.
I'd like to start by seconding everything Roy said. I think it's inevitable at this point that digital interventions, not just for health, but in any other aspect of life, it is very, very crucial, and it's important that we integrate it in our systems. So I'll start by giving a little bit of context of the Pakistani landscape. So in Pakistan, there's a serious dearth of mental health experts for service provision, with like a recent informal study suggesting that there are around 3,000 psychologists and 500 psychiatrists for a population of 200 million plus people. So that is a huge gap that exists in our landscape at this point in time. So post-COVID, what we realized and what we started seeing is that the trend of health provision or health service provision changed quite a lot because everything shifted to digital. And since then, the trend for tele-mental health services has started in Pakistan, and Taskeen itself obviously offers tele-mental health services. There are a lot of organizations, private organizations and public organizations that are offering these services. Now, what this really helps is bridge the gap of affordability and accessibility, because what we have seen since 2019, earlier 2019, when we started the helpline, was that people who are in the most remote parts of Pakistan, who probably do not have access to the internet or a smartphone, what the helpline does is bridge that gap and make that service available for them. And what we've seen is a lot of minorities have been able to take a lot of advantage from such services. So we're talking about youth who do not have access to, let's say, to go to a psychologist or a counselor without, guidance and stuff. Or we're talking about women who are at home and who cannot leave the confines of their home to go seek help or just, talk to someone. So those kind of, target groups, those exist, and those are realities in every region in the country. So it really helps to extend that kind of service to them. And we've also interestingly realized that a lot of expats, and we're talking about blue collar expats that are not in Pakistan, they also use these services because they need contextually relevant kind of service provision, because obviously you can't expect someone to understand the kind of issue. So they do refer to our helpline to get in touch with us. And another interesting thing is that the government is also taking a lot of interest in this, and they want to probably in the near future start a national tele-mental health service or a hotline for that. Another interesting intervention that I would like to talk about is that earlier this year, we started an AI WhatsApp chatbot. So what the chatbot does is that it provides its service as a screening tool and also as an appointment booking system. So initially, when someone would contact us, they would have to go through a helpline coordinator, asking them details about where they're from, their age, etc. Now, all of that system has been digitized. So anyone who wants to get in touch, the WhatsApp chatbot gets all of the details. So their name, the region where they're contacting from, their gender, what they want to know. So all of that has been digitized, and it actually has accelerated the process of service provision. And we've also introduced recently a suicide basically ideation screening as well. So anyone who's come in with suicide ideation is booked for an urgent session right away, because depending on the severity of the situation. So that in itself, I think, is one of it's a great intervention, and we want to expand it to other kind of public organizations too. Other than that, I think one of the most important things, which I think is available to everyone, is social media. And I'd like to talk about this because social media is everywhere, and it is very important that we make use of it to talk about mental health. And what we do here at Taskeen is that we do a lot of creative storytelling. So we communicate about mental health and mental health awareness and the psychosocial determinants of mental health distress through creative storytelling, and also by highlighting the experiences of people with lived experience. And this is something that I think is very, very important in the landscape of mental health, is to talk about people with lived experience, because the experience that they bring in to the conversation is unmatched. And it really, what we've realized, it creates harmony. It brings people together. We've had a lot of people who've come in to us and told us that we saw this story and it really helped us feel that we're not alone in this journey. So those are some things that we're doing, and I'm happy to be talking about this. So yeah, thank you.
Such great insights from this morning's session, which makes me very excited to now get into this discussion with our panelists for this particular session. But before we get into that, do remember that you can send those questions for the panelists in the Q&A section right here on Zoom, and also send any comments in the chat box. We're very keen to find out what you have to say about this particular discussion today. So with that being said, let's get into the discussion for today, the topic for today. And Fajana, let's start with you. I'm keen to find out how local communities in Bangladesh have responded to the use of digital interventions and how this has impacted existing approaches to mental health care in the region.
Thank you again, and good evening from Bangladesh again, and thank you for inviting me this crucial gathering focusing on mental health webinar series. And I like to thank respected guests and participants joining us from various corners of virtual world. I deeply honored to be speaker and also delighted to be part of journey together to explore, understand, and support one another in realm of mental well-being. Today, I'm gonna speak about from my organization, BRAC. I'm working in BRAC Health Program, and BRAC Health Program is successfully established a digital platform for community health worker, which is known as Shastu Kurmi and Shastu Shebika. We have around 4,000 Shastu Kurmi and 35,000 Shastu Shebika who have been working in the community level, hard-to-reach area, hillside, and around the country since 1972. So in 2022, actually 2020, BRAC Health Program has successfully launched a mHealth service. And in 2022, all data entry in the community level generated in digital platform. In 2023, this year, whole BRAC program facilitated the service in digitally. So as a part of BRAC Health Program, BRAC Mental Health have been working since 2019, and we have successfully initiated a pilot project that I have been talking in the beginning of my conversation, that Bangladesh government have been collaborate with BRAC to do a pilot project to integrate mental health into primary healthcare. And when we start to plan this intervention, from the beginning of the intervention, we had started to think about how we operate the program in a digital way, so that it is very effective and scalable in later on. So among our community health worker has been working in from the beginning of 1972, as I said earlier. So our community health worker have great access, trust, and proficiency of primary healthcare in the community level. And they have been trained in mental health primary screening. And they are working on sensitization, awareness, breaking the stigma at the doorstep. Along with our community health worker, we have introduced a new cadre that is known as lay counselor or paraprofessional, who have been working solely in mental health and provide the psychosocial service those who needed the services. They do some preliminary assessment and provide basic counseling at the community and domiciliary level. All the assessment, screening, data entry, psychometric tools have been done digitally in SPICE app, both para-counselor and community health worker. When community health worker able to identify a client with mental health issue, the information, client identification tool scores are automatically informed and shared to the paraprofessional. In the next day, the paraprofessional will able to visit the client house and provide the psychosocial service and use the detailed information that been shared in the apps. So client get the service from the paraprofessional without any delays and repetition of sharing of the same information. So already the community health worker do the assessment, and the detailed information also has been shared in the apps. The paraprofessional just assess or access the information and provide the further treatment. In if any client has some severe mental issue, like any risk factor, can be client have some suicidal ideation or self-harm or suicidal thought, the para-counselor and community health worker immediately refer the client to the government facility where they can get the further treatment from the psychiatrist or the clinical psychologist or psychologist. Right now, we are able to synchronize the digital platform, community health worker and the paraprofessional. But further, we are thinking that we want to link this digital platform where the government facilities are available and the government staff is working in the mental health initiative. So this innovation will help the reduce the treatment delay of the population of Bangladesh. And as national statistics shows that any person with mental issue take 36 months to take first in treatment from the mental health expert. So it will help generate, it also help generate national level data on mental health. And as you know, the globally, there is lack of many mental health research finding and that data regarding mental health illness. So it will help a research bank for the national level, and it will help the government and all the policymaker, of course, technical partner to plan and implement and take the appropriate action in next level. So when we think about the digital mental health innovation, we do believe that there is a lot of factors that need to be considered, like culture acceptance. Like in Bangladesh, there is 70% people are living in the rural area. So all the people in the rural area do not have the smartphone. So if we think about any apps or any digital social platform that will able to help them to take the treatment, that will not actually realistic plan, because people do not have the digital access or the smartphone device or other thing. So we try to bring the digital intervention to their doorstep so that they can able to get the treatment and assessment. And if they have any vulnerable issues, they can get the immediate treatment from the government facilities. So that's why we are thinking that when we're thinking about this innovation, we need the accessibility and collaboration with the various stakeholders, including healthcare professional and policymaker, and of course, not in the least, the technical developer. BRAC has been working on this beginning of this factor, and our digital mental health innovation is trying to work on integration of mental health into primary healthcare screening, the community level. Secondly, we want to have a real-time data and baseline data of the individual with the mental health issues, both urban and rural area. And we want to develop a monitoring evaluation of each paraprofessional or the community health worker in the programmatic aspect so that we can develop our program in further and in scalable way. And also we can see the client improvement. And we also think about how this innovation can be scalable and we can fit with other area where there is no services. We can bring this innovation to those areas there is no government facilities, but a paraprofessional or a community health worker can bring the service to the client and the doorstep. And we also thinking about that this cannot be done alone. So we are thinking about the opportunity linkage with the government facility and alignment with the government mental health initiative. So this is the 5 factors we are thinking from the beginning of our planning, and we are thinking that this innovation gonna help in the community of the community people and also the other whole over the population. And there is around 169 million of people living in Bangladesh, and there is like 18.7% has the severe mental health problem and require the emergency care, because mental health specialists are very limited in number in our country and non-existent in the rural area. And if we think about that why people do not seek the treatment from the mental health illness, we can't tell that as there is no services in the community level, and there is stigma and taboo around the mental health illness, and there is 92.3% people do not seek any treatment. So when we have only 800 mental health experts, 300 psychiatrists and 500 psychologists or clinical psychologists, and around 500 psychosocial workers is working in this area. So should we wait for the enough mental health professional, which will take 50 years to to meet this target population, or Bangladesh National Mental Health Budget only allocated 0.44% in total budget. So which is insufficient to support this creation of paraprofessional in the field. So should we wait for this creating mental health professional or making a paraprofessional? That is very unrealistic. So Brad think that using an existing mental health professional and digital mental health intervention to connect the community healthcare facilities would be a solution for the scaling up of the mental health services. So that's why we are working with the government and along with the other stakeholders to bring this solution to the community level. So this is our intervention we are working right now, and hope we are in next year we are going to scale up with the other area with the collaboration with the Bangladesh government. So thank you for today, and I'd like to thank the United Government Mental Health Care for giving me the opportunity to share my experience with you all. Thank you.
Thank you, Bajana. It's been very interesting hearing you talk about the work that's been happening in Bangladesh around mental health interventions. And also just thank you for acknowledging the fact that for a majority of the population, access to digital mental health is still an issue because of the lack of access to the internet. And that what you're looking at, and this is something that one of our participants in the chat is acknowledging, that it sounds like what Bragg deploys is a really holistic approach to mental health innovations. And earlier on, we also had a comment from Fahana, who was really keen to find out about digital health services in Bangladesh. So I really do hope, Fahana, that this is giving you insight into what's happening regarding mental health interventions in Bangladesh. Thank you for sharing, Fajana. And let's move on to John. John, I'm curious to find out from your perspective, how are machine learning methods identifying new patterns in mental health to help predict illnesses? And how do these findings translate into personalized interventions for individuals experiencing mental health challenges?
Yeah. No, it's a good question first, and thank you all for inviting me. And I think there's a lot that machine learning can do that we've heard about. So I'll kind of take you quickly through a journey of how I think it has clinical applications and what you can do. But I think I'll start by saying there's a lot of digital tools that are out there. Not every digital tool has to have machine learning to be helpful to people. I'm sure, as Dr. Carswell will say, there's a lot that you can do with self-help apps. So we have this database, I'll put the link there, where you can just look up about 600 different self-help apps and see which ones may be a good match for you, for people you work with. We sort them by things like price, because that matters, by privacy, because that matters. And some of them will involve artificial intelligence, machine learning, some won't. But to basically begin to really use machine learning to help predict how people are doing, to do preventive mental health, we realized that a lot of the existing tools that we saw in the market really either had privacy issues, they were so costly, they just didn't work well. So we built this open source research tool. I put the link in. And what this does is you can customize it for your language. We use it in India, we use it in Asia, we use it in Australia, we use it in South America. But the idea is that different people will program in the questions they want. They'll get things like step or sleep as they want from the phone, and we can use that for predictions. But even if, let's say, we can collect information on the phone and you can say, John, I understand your sleep is different and your mood is different and your activity, and I think you're not doing well. What we found and as I said, Dr. Sharma talked about, you kind of still need a person to help interpret that result. We don't have enough mental health clinicians. So even if you have all these results about someone's not doing well, how do I help? You need something that we've in part called a digital navigator. This is a link to a paper account this week of kind of saying, what is this new role for people with lived experience, for maybe non-clinicians, to begin to help support different digital interventions, including machine learning. And because, again, in that review paper, we outlined all of the different ways you could do it, but we wanted to put out this completely free training that anyone can take. It's web-based, to kind of learn about what could it be like to be a digital navigator. And that would include skills helping people get a phone and connect to the internet, helping people make smart decisions, helping people stay engaged. So a digital navigator is not a clinician, but they're facilitating access and equity and engagement with different digital tools. And I know we've talked about a lot of pieces from self-help apps. We have an app that can help do this machine learning. We have a digital navigator role, but I'll send this paper out to PDF. This is the last one of a link. We actually have built a clinic at Harvard Medical School where we take patients, we give people regular telehealth visits, standard of care, but we actually use the app to augment and supplement care. And I think the key word there is to augment and to supplement. We're not changing the standard of care. We're not reducing your time face-to-face, but outside of the session, you're working with our digital navigator to collect information about your steps, your sleep, your mood, so we know what's happening. And your practicing homework skills are customized just to you. So when people come back for that monthly or weekly visit, they've done so much activity and we're able to understand their lived experience better and personalize care. So I think that machine learning is a part of what we can do, but you can see it really involves a lot of more. Can we have a workforce of digital navigators? Can we have tools that we trust? And can we have clinical workflows? But all of the links I shared, these are things that our team shares openly with teams around the world. There's not cost for running them. And I think what's exciting and it's amazing to be here is to think about, could we again help share more of these resources with teams like you guys? Could we start to implement some of them? Some are simple to implement. You can just go to mindapps.org and look for apps. Some are a little bit more, but thank you.
Thank you, Dr. John, and big thanks for also sharing all of those resources in the comment section. I'm sure the people tuned into this webinar will definitely appreciate all of those resources that you've just shared with us. And let's get to Dr. Ken from the World Health Organization. Dr. Ken, I think my question to you is, does the World Health Organizations have any recommendations concerning digital mental health tools, and how do you see the space evolving over the next few years?
Great, thanks, Malebs, and thanks also for this webinar and for everybody attending. It's been for me a fantastic learning opportunity as well to hear these different experiences of implementation and the research that's going on. So it's been a really rich discussion so far. So I'm going to talk a little bit about some of our work at WHO and particularly recommendations around digital. Now, when we think about digital mental health, as we've been saying, we might think about self-help apps. We might be thinking about delivering therapy over Zoom, over video conferencing, and so on. There are many different formats that we might think of. We might also be thinking about prevention and promotion interventions. How do you give information to people? I won't be able to cover all of those, but I'll try and focus on a couple of them. Well, the first thing I want to mention is around recommendations from WHO. We very recently updated our treatment recommendations for mental, neurological, and substance use conditions, and we published them last week. Now, these are recommendations that cover all types of treatment for different conditions, but in this revision of the review, there's quite a focus in some of the conditions on digital. So there are now different recommendations around the use of digital interventions, primarily self-help, for alcohol and substance use conditions, anxiety, PTSD, self-harm and suicide for people with suicidal thoughts. And this supports some of our existing recommendations around the use of self-help with depression. So what we're seeing from those recommendations, and they're obviously based on the existing evidence base, is that there is a lot of evidence out there for digital. The different uses, how they might be used, might vary, but overall it's looking very, very promising. So we can see that there is a lot that can be achieved through different digital interventions. And we also sort of see in the literature that by doing therapy or an intervention over a video conferencing, they seem to be as effective as doing it in person. So there's a lot there to be confident about. But there are a few barriers to scale up. We've heard of some great examples where things are being scaled, but generally, and particularly when it comes to self-help interventions and the wider field of psychological interventions, we can see gaps sometimes because we see that despite all this great research, all this evidence that these things work, actually accessing some of the interventions at work can be very hard. So for example, people might test something, but then after the test, it doesn't reach scale, it's not commercially or publicly available. And so there's a bit of a barrier there. And this is something we've been working on at WHO for several years now to develop what we call scalable psychological interventions. And the aim of this is really to develop different interventions, both digital and non-digital, test them in randomized controlled trials, and then release them as open access for people to use, implement, change, adapt, and for it to support some of the great work that we've heard today. And just to give you an example of one of them, we have an intervention at WHO called Step by Step, which is a guided self-help intervention for depression. And this was tested delivered through an app. And this was tested in 2 different randomized controlled trials in Lebanon. And it's an app where you read a story about somebody who has depression, and they go and seek help from a health professional. And by doing that, the user of the app learns these different techniques to help them manage their own mood and their own depression. And in addition to that, it was also tested in a guided version. Now guided means when you talk about guided self-help, we mean self-help that's provided with some form of coaching. And in our version of this, we provided the coaching through a 15-minute telephone call once a week. But we also know that unguided interventions are also effective, and they could also be very helpful, particularly across a population level. So people receive this intervention and the 15-minute telephone call, and we found in the randomized controlled trials that it was very effective. Many people had a treatment response. We were really quite pleased with the results, and this is now being scaled as a national service across Lebanon. And this is an example of how we can hopefully increase access to the digital interventions, because Step by Step is available as open source. We'll be publishing it next year, and all of the interventions are on the web links that will be shared. But once they're out there, it means that people can be relatively certain that after adaptation, cultural adaptation, thinking about how it might fit into their context, that there's something there that might work. So that's some of the sort of advice, guidance, recommendations that are coming out from WHO. And just to really mention, I mean, I suppose in the next few years, where it'd be good to see things going is really a big focus on implementation, because there are some fantastic things going on right now, and to be able to learn more about those, to learn how we can deliver them safely, how we can integrate them into health services, because obviously digital is one aspect of a service mix, but it can't ever be the only one. So we've got to think about, how do we integrate these things? How do we ensure that people can get other help when they need other help? How do we step people up to other forms of help? And trying to understand that across bigger implementation studies, across bigger areas, will be hugely fantastic to the field, I think. And will also give learning probably for the more advanced types of technology that are coming on, like machine learning and AI, and these things that I'm sure will also provide very interesting results and ways, hopefully, of both addressing mental health through, for example, self-help, but perhaps also helping services to understand more about populations, or to be able to provide responses, like, for example, with some of the examples we just heard today. So thank you.
Great. Thank you so much, Dr. Ken. And a request coming from Katarina in our chat box, who is asking if you could please share the link to the latest recommendations from the World Health Organization published last week that include digital health tools. Great. Just a reminder again that you do have any question, pop them into the Q&A section, and I'll get started with the first question that we've received from Kamayani Bali, who wants to know, how do you manage when doors are closed for the community health worker because of stigma attached to mental health issues? And I think, Fajana, you can let us know how you've dealt with that within your organization.
Okay, thank you so much. This is very crucial question. As I'm saying that the culture background is really important factor to implement any kind of intervention. Our community health worker has been working since 1972 after our liberation war. Like they have been working very long period of time, and they are working primary health care. So they provide the services like antenatal care, postnatal care, counseling to the pregnant women, and provide the vaccination. They are providing a lot of intervention and treatment or the services to the doorstep where there is no facilities in the government side or any NGO side. So people trust the community mental health worker. So when they work with the physical health, they have been starting to share their mental health issues too. But since the community health worker from BRAC were not trained about this mental health issue, they could not link with why they are telling about the certain symptom that is not described as a physical, but rather than psychological. So when they get the training from our program, and they started to work on and link with that physical thing is very related to mental thing. And when you have any physical issue, it is normal to have mental health issues too. Then they are started to communicate, and they are started to share their mental issues too. So the empathetic listening they have been using in the service providing in the community level, and the trust and accessibility and everything actually play the key role to our community health work to bring the service in the community level.
Thank you, Fajan. And you touched on something really important there around the fact that people trust community health workers. Being able to create that personal relationship is also crucial, when it comes to the provision of mental health services, particularly at a community level. And I think, with all these digital tools and interventions that exist and continue to be developed, as great as they are in combating some of the mental health challenges that exist within our communities and societies, they can miss that personal element where a person can be able to create trust, with a community health worker. So thank you for touching on that. We do have another question from Leandri, who wants to know, and any of our other panelists can take this question. With the plethora of digital mental health interventions out there, how do we ensure safety and efficacy, as these don't usually follow the same process of scrutiny and evaluations as traditional drugs and interventions before coming to the market? What a good question. Any one of our panelists that would like to answer that?
I'll take a quick start at. I think it's a very good question. There's so many digital mental health products, and they all have such wonderful marketing. But I think that, at least from a US perspective, we've seen some very terrifying privacy breaches of people's personal mental health data. And I think it's made us realize that because a lot of these products say that they're wellness products, not medical products, they actually have no laws that protect people's data, even though they look like medical products. So there's a little bit of deception sometimes going on. So I think one reason is why on the mindapps.org website, we actually have a whole section on privacy. So we read the privacy policy for you, and then I'm not here to tell you what level of privacy you or the people you work with want, but I think it's actually the thing I recommend people start with is understand the privacy, because sometimes it's not as great as it wants. I think to understand how all these things work, one of the roles I have is I edit many of the journals where the academic evidence comes out, and we've seen that a lot of digital health products are compared to nothing. They say one group used an app and the other group did nothing. And I think the argument used to be that, well, there's such a lack of access to mental health services that comparing an app to nothing makes sense. But if you think about it, most people now have a phone, we heard, so you really should compare it to information on the phone, to playing a game on the phone. So I think as we're seeing that the scientific level of evidence goes up and there's better comparisons, I think in the next year we'll learn which apps and programs really work well and which ones are perhaps more okay, they're not harming someone, but they're not as effective. So I think that I would just encourage everyone to be optimistic but skeptical, to ask the hard questions. When someone says this is great, I would say, what is your privacy policy and how did you compare it to a standard of care? And show me it's better, because there's a lot of really good free stuff at $0 out there that you can find and use today.
Absolutely. It's important to ask the hard questions indeed. I absolutely agree, Dr. John. And a question for Dr. Ken. What experiences do you have with bringing clinicians on board with digital solutions? And this person, I can't exactly see the name for now, but they say that they tend to struggle with that in the National Health Services in East London. So they'd be interested to hear any tips regarding that.
Great, Malabs. Thanks for the question. It's a very good question and a very relevant one. I don't think there's any one approach, and I think that probably the approach varies by country. I mean, I used to work in the UK myself. This was quite a few years back, where digital interventions were starting to be used, and certainly back then, as a clinician, I found it hard to sort of think how would these actually sort of suit people. Now, seeing it at a more global level, seeing the evidence that sort of increased, also sort of seeing some of the different reports of some of the more innovative apps and how they're used, and particularly sort of seeing the results that you can get. And now you fully support them. I don't think though that it's necessarily that they're right for everybody, and particularly say in a health service like the UK, there might be a desire for clinicians to provide people with in-person, face-to-face treatment. So I guess a first way is really maybe around advocacy and information around how effective they can be, that they can be effective for people with more severe problems as well as milder problems. But also maybe sort of thinking about, well, how does it fit the person? What is more or less suitable for the person? There may be some populations that might find it difficult to access a health service, where a digital intervention might be more tailored to them than an in-person intervention. And I think that some of this is around really maybe communication and letting people know the sort of strength of the evidence. And perhaps quite a good way of doing that is around a more sort of localized approach in terms of piloting, adapting, trying to use something that's more suited to the community or area where people work, so that then clinicians might see results. But I would say this is something we see in many places, and the sort of approaches that I was sort of mentioning there are some of the things that we try. But it's definitely a challenge there. And I think that mainly comes from a good place of people wanting to give the best sort of support that they can. Yeah.
Yeah. Thank you, Dr. Ken. A comment coming through from Emma, who's saying it's such an interesting point. They work in this area and there's a huge gap between wellness apps and medical apps in terms of regulations. If it treats a medical issue, it counts as a software, it counts as software as a medical device, and there's a huge amount of regulation, although this poses lots of research challenges. Thank you for sharing that, Emma. And there's a question coming from Ranjan Morris, who wants to find out, well, the context here is that there's still significant inequalities in Australia among First Nations people, where access to technology is a problem and suicide rates are high. What could be done to address this inequality? Fajan, would you like to respond to that?
There's some inequality, and in mental health aspect, I think it is very much visible. we can see in the community level, and there is a lot of things play a vital role for this inequality. Like if I say from my country, from Bangladesh, so in my organization or any other organization, when people have some mental health issue, if they express their issues to the organizational level, they are considered as a low performance employee. And in family member, women are not very much encouraged to tell their mental health issues in the family member. We are suppressed. We have also tried, always we have taught that please keep all your problem in your inside, everything gonna be okay, and you are weak if you express your emotion or problem. And lot of things actually play a vital role. So I think if we work on in create a prevention approach and awareness, and also create a small space group in the own community, so people can learn to express that space. And also we try to identify the vulnerable cases, the people who have the high risk factor, and they will get the services from the mental health expert. And if we try to keep a intervention process, that they will immediately get the services from the facility level, or get any online counseling services or any tele-counseling services from the NGO level, or whatever the services available in the own country. I think there is always a hope for working on this vulnerable group of people. And I do believe it's not any government-owned responsibility to work on this. We have to work together, the NGO partner, local NGO, CSO, like civil service society, or any community health worker, those who are tremendously working on this sector. So we have to bring them all together, and also not in the lead people with lived experience. We have to include them too in the planning, implementation, and action. So I think if we work together, so I think we will be able to overcome these challenges.
A very important point right there you just made, for Jana, around including the people that have the lived experiences of this challenge in the solutions that are created. Thank you so much for sharing, and I hope that was helpful for you, Ranjan, in relation to your question. We have a couple of comments coming through. One person saying, thank you for sharing your thoughts. Ken Caswell, very helpful. I definitely agree that clinicians are always coming from a good place of wanting to safeguard their patients. Spirit Clinton also saying, I wonder if you all think that assessment and treatment may be a step ahead of many populations, and that maybe more emphasis should be given to psychoeducation and awareness related to mental health, a question mark there. We also have Mudube, a mental health nurse and social worker, who says they've worked in this area in Ogun State in Nigeria, and it would have been a great opportunity to reach out to service users, but often lack access to digital media by people that come from rural areas. Such insights coming from our participants in this webinar, and thank you so much for sharing all of your experiences. I think where we are now, if there aren't any additional questions, we're just getting ready to close the session. Let me just see in our Q&A section. I think let's just take one final question and then we can finally wrap up. I see there's a question coming from Ishtar, who wants to know, well, with the pandemic, there was an increase in online therapy and remote mental health care. Do you think this form of mental health work is a trend that will continue to grow with technological advances? And is there evidence that online therapy has an effect on improving people's mental health? I think we can try get an opinion from all of our three panelists before we close off for the day. Anyone that would like
May
to
I?
go?
Okay.
Go ahead.
Okay, in Bangladesh, before the pandemic, it's very not acceptable, and also client want to get the therapy in person. So when pandemic happened, so many clients, as I'm a clinical psychologist, many clients reach out me to get the online services. And from the beginning, I feel a little bit uncomfortable, because as I know, and many research finding, we have seen that the online basis is not effective as in-person counseling session, right? So there is no other way in the pandemic situation. We have to give the service to the vulnerable people. So later, after the pandemic, the trend also continue, and many clinical clinician or psychotherapists or the clinical psychologists has been continuing these online services in digital platform. I think the demand has been created, and the situation also demand that we go to the in-person to online business services. I think it is a good practice. And if we establish a standard procedure in giving the digital platform or telemedicine, I think there is no harm to continue these digital mental health services. This is actually my experience and my opinion.
Thank you, Farjana. And Dr. Ken?
I think I would just say very, very briefly, because I was short on time. I would completely agree. I think that there's a huge change as a result of the pandemic, and many services went online. I don't think it'll ever replace, and there has to always sort of be a mix. But I think we learned a lot, and as long as I think they can be effective, and as long as they can be delivered safely, confidentially, there are maybe adaptations that need to be made. We've got to ensure that people can receive additional help if they're in danger or anything like this. Then they can be effective means. And I think there was a huge change as a result of the pandemic with that.
I'm not sure if you can all hear me. Okay, so I do think I agree, but I think it'll be more these hybrid care models where there's synchronous telehealth video visits, but in use of technology to augment and extend it. So I think that we have to build these synchronous models, but that takes digital navigators and a new workforce to facilitate a new type of care model. So I think we don't want to go all telehealth because it's not scalable. We don't want to tell people it's all apps and chatbots because that's just not going to work. But I do think we have an opportunity to kind of find this middle course. And I think a group like this that can help define standards or pilot it in a global setting can quickly show it can increase access and quality.
Wow. All right. Thank you so much for sharing. And just as we wrap up, because I am conscious of time, for everyone attending the session, any questions that are unanswered, we will make sure that our panelists do answer them on Circle, which I'll tell you about in just a moment. But as we wrap up, I'd like to find out from our panelists, just to complete this sentence in 30 seconds or less, to make digital mental health interventions a success, we must ... What is it that we must do?
Build them for hybrid care models.
Love it. Thank you, Dr. John. All right, and I think yes, Dr. Ken?
I think I'd say to implement, integrate, continue to learn, and particularly continue to share information.
And anything from you, Farjana, as we wrap up?
Using the existing human resources and health sector and digital intervention collaboration
100%
can be a solution.
Right. Thank you so much. Thank you to everyone who joined us for this webinar today. Thank you to our amazing panelists today. I'm sure that the rest of the audience really appreciates how insightful this discussion has been. The next webinar is scheduled for January 2024, and the topic will be on the health workforce. The registration link is also in the chat, so make sure you do register for that event as well. I'd also like to encourage you to continue the conversation on Circle right after this. The link to join should be in the chat box. Circle is a virtual networking space for Global Mental Health Action Network members, where you can meet and discuss issues in real time, share information about the work you do, as well as promote the work that you're doing across, mental health in general. And as I said, for all of those questions that were answered in this particular webinar, we'll make sure that our panelists do answer them on Circle. Otherwise, follow United for Global Mental Health or Global Mental Health Action Network on social media channels so that you don't miss out on any of these types of events in the near future. Thank you so much, everyone, and do have a fantastic day.
Thanks, everyone. Bye-bye.